And so I shall. I want to welcome everybody to the Positive Behavioral Interventions in Community Settings for Family and Caregiver series, aka our Parent Cafes. I'm looking through every one of the participants right now, and we are all muted. That's awesome. Before we get started, I want to do what our due diligence of the most, besides our speaker, the most important thing is thanking our wonderful sponsors today, the Kansas Cabinet and Trust Fund and All In for Kansas Kids. Keep your camera on if you feel comfortable. If not, not a big deal. You are on mute, but in working with Christy yesterday, she is extremely excited about having an interactive presentation. So she will be asking for questions and bringing some things up there. We also want to thank KU Med, but we can go to the next slide now, Christy.
Now I have it in presenter mode and I don't know how to move forward. There we go.
There you go. Okay. So what we would love is if you could put in the chat who you are, the organization you're affiliated with. If you're a parent and you're just here to observe that, say just parent of a kiddo, that's fine as well. Email address would be wonderful so we can keep you up to date with what we're going to be doing, including our next presentation, which will be with Dr. Linda Heitzman-Powell. Speaking of which, we want to thank the University of Kansas Medical Center. They are one of our hosts with Dr. Linda Heitzman-Powell. And then our organization is Integrated Behavioral Technologies and the Kids Place, our childcare facility in McLeod. And our presenter today will be Christy Stiehl. But we can go to our next slide and I'll introduce her in a minute. Our agenda for the day is a little bit of an introduction for the first 5 to 10 minutes, presentation for about 45 minutes, and then some discussions. But like we said, we're going to be very much an interactive. So keep those questions going. And then we can go to our next slide. You know, we will be doing assessments. We did one prior, but we will also be sending out at the end of our presentation by Christy, we will be sending out a post-training survey just to get some more information from you guys. Please feel free to fill that out and be honest, give us some feedback about what you thought about everything from the subject to the timing and everything that goes with this presentation. We enjoyed the feedback. We've actually gotten a few ideas and found some great topics from those suggestions. So okay, and I will let Christy talk about that in a second, but at this time it's my absolute pleasure to introduce to you Christy Stiehl. She owns her own ABA practice, Stiehl Behavioral Consulting LLC in Lawrence. She is not only a wonderful worker in this profession, she is also now a new trainer in how to present on Google, that she said earlier. But among the other things that she does and is so engaged in this community, she's an outreach and advocacy by serving on the board of directors for Autism Society, the Heartland, also known as ASH, the Behavioral Analysis Advisories Committee for the Kansas Behavioral Science and Regulatory Board, and the Kansas Association for Behavioral Analysis, and the co-chair of the Professional Development Committee for that. So we are so excited for her wonderful topic. Without further ado, I turn it over to our presenter today, Christy Stiehl.
Thank you, John. I appreciate it. And thank you, everybody, for being here. This topic has been on my mind for a few years. I went to a talk and it was put on by dentists in the community. And they were kind of they had some initial strategies for folks to try with their kiddos. And then if their kiddos couldn't tolerate that, then they were recommending sedation and anesthesia. And that really threw me off that there weren't no behavioral strategies recommended or, any type of previous interventions recommended before just jumping straight to sedation. And so I definitely am passionate about getting the word out there that there's a middle ground and there's things that we can try before jumping to more riskier interventions to make sure that individuals with intellectual and developmental disabilities are getting access to dental and medical care. And so John has a slide up for me to remind me to let you know that the information that I'm presenting is based on research and evidence in the field and is currently accepted within the profession. So I'm not making anything up from my own personal views in this presentation. And at the end of the
Christy.
What was that?
I said, oh, come on, let's make it
and I do have my references at the end of the presentation. So if you check out the PDF slides that they'll send out, that is in there as well if you want to look further into what I'm talking about today. My primary reference is a paper that just came out in this year in regards to teaching dental professionals to implement some of these practices. And there's a really nice lit review in there of the current research and supporting evidence. So that it's an excellent article that I recommend checking out if you're a professional in the field and interested in more. Okay, so as John mentioned, my name is Christy Stiehl. I have a practice here in Lawrence, and advocacy and community involvement is very important to me. And so I'm very happy to be here today and to talk with you about dental and medical appointments and behavioral strategies that can be implemented prior to jumping straight to more invasive procedures like restraint, sedation, and anesthesia. And this presentation follows a general PBS model. And so the PBS model starts with primary intervention strategies that can be employed for everyone, secondary prevention, which is focused more on specialized group and at-risk individuals, and then tertiary prevention, which is for very specialized, individualized, and for individuals at high risk of deficits or challenging behavior. And so in my presentation today, I'll first touch on the current needs and practices in medical care. And then we'll start with some primary prevention strategies that caregivers can employ for their individual that is in need of dental or medical care. Then we'll go into secondary prevention strategies that medical professionals can employ. And then third into tertiary prevention, which is when a behavior analyst would likely be involved in the intervention. And then ending with a discussion. But of course, if there are questions or comments throughout the presentation, this can definitely be interactive as well. Just some clarification on some terms that are used throughout the presentation. ASD is for autism spectrum disorder, IDD, intellectual and developmental disabilities, which includes autism. ABA stands for Applied Behavior Analysis, and a BCBA is a board certified behavior analyst. So a clinician licensed to practice behavior analysis and behavior analysis. Okay, so why does this matter? As I think is common knowledge, routine dental and medical care is important. It reduces the risk of other serious health issues like cardiovascular disease, coronary heart disease, and diabetes. So good health is critical for everyone. What we know currently is that individuals with IDD have less access to this routine healthcare and poor health outcomes, and that common barriers resulting in this in less access and poor health outcomes are anxiety, non-compliance, and dangerous behavior surrounding these medical procedures. Dangerous behavior meaning behavior that could interfere with the safety of the procedure. And what we also know is that in terms of dentists specifically, they receive little training and often report feeling unprepared to serve individuals with intellectual and developmental disabilities. And that because of this, some dentists choose to exclude patients with IDD, so they just don't see them at all. Or others require use of restraints, sedation, or anesthesia if there's any intolerance to the procedures, or potentially if an individual has an IDD diagnosis. And so there are other options besides just excluding folks with IDD from their practice and jumping straight to restraining, sedating, or using anesthesia to complete medical procedures. And those are behavioral strategies. And we have extensive research on behavioral strategies that have been shown to be effective for individuals with IDD in terms of tolerating these medical appointments and procedures. And it doesn't mean that they'll always be enough. It might be that the behavioral strategies don't yield results fast enough for an individual's medical needs, or there may be times where restraint, sedation, and anesthesia are necessary, or the benefits of those options do outweigh the risks. But this certainly gives families additional options and individuals additional options to consider before going straight to those more restrictive procedures. So the strategies I'll be talking about today are based on the principles of applied behavior analysis, or ABA. And the goal is to increase compliance with the medical procedures, reduce dangerous behavior, and or reduce the fear or anxiety around those procedures. And today I'll be primarily talking about dental procedures, but these procedures can easily be applied to other health and hygiene tasks that can be aversive to individuals. So that can include things like blood draws, nasal swabs for COVID tests, shots, vaccines, physical exams, haircuts and hair brushing, teeth brushing and flossing, and nail cutting. And personally, or in my professional experience, I've worked with individuals to successfully complete blood draws, get COVID vaccines, go through a routine dental cleaning, haircuts, teeth brushing, nail cutting, and I can vouch that these strategies can be applied in these settings as well. And we have research to back it up too, just not me vouching for it. So in terms of primary prevention, things that caregivers can do for all their kiddos, for all people, to make the dental or medical visit more tolerable and more likely that it's a successful outcome. The first is to identify a professional who is trained and experienced, ideally, with supporting individuals with IDD and completing their medical procedures. What can be helpful is if a caregiver is contacting a professional, looking to locate a professional, is to describe the needs of their kiddo or their learner, their patient, and really to make sure that the professional is willing to try some simple intervention strategies that could help that individual have a successful visit. The other thing caregivers can do is preparing the patient ahead of time. So, talking about the visit, engaging in pretend play on a stuffed animal, imaginary play. There's some videos out there on YouTube introducing kids to dental visits, reading a book about it, potentially visiting the dentist office or the medical office ahead of time, meeting the folks that the individual will receive care from. All of that can help to do ahead of time. Additionally, bringing a security item can sometimes be helpful. So in this picture, this kiddo's got a teddy bear, but it can really be anything that makes the individual feel safer, as well as bringing a distraction. So something like a tablet, music, TV, even a parent just talking to the child or giving them squeezes on their arms while the medical procedure is taking place. And then it can also be nice to set up something fun afterwards, like going to get ice cream, going to the toy store, a movie, a favorite restaurant. In this picture, this kiddo got to go to the trampoline park. And the intent here is that you're pairing going to the medical appointment with a positive experience, something to look forward to afterwards, just making it a little less painful of an experience. So those are procedures that parents and caregivers can implement with an individual who is going to a medical or dental appointment. These next strategies are kind of the second line of defense or the second line of intervention that medical professionals would employ during the medical appointment. The first is what's simply called tell, show, do. And what that means is that the professional would first tell the individual what they're going to do, show them what they're going to do, and then do it. And so this is important. This tell and show are the important parts, that you're doing those two steps before implementing the procedure. So for a dentist, this could be, here's my pokey tool. I don't know the technical terms for it. And I'm going to touch each of your teeth with it and, model what it's going to look like before doing it. So letting the individual know what's going to happen and showing them what that's going to look like. The second is praising compliance with the procedures. So just letting them know that they're doing a good job throughout each of the steps. Third is providing access to preferred items. So if the individual, if it's helpful to have a movie playing, if they have a favorite movie playing, if they have a TV in the room, or having a tablet playing music, or something that that is preferred that they want to hold on to, or that can help as a distraction, giving those preferred items can help with that procedure as well. And then the last two are related to giving breaks. And so we want to schedule frequent breaks from the procedure. So sometimes that looks like, starting with every 15 seconds, we're setting a timer. And when that 15 seconds is up, the dentist or the medical professional stops, backs away for, 5-10 seconds, and then they go back in for another 15 seconds, backs off. And so these scheduled frequent breaks give the individual information about when this unpleasant situation is going to be over. And those frequent scheduled breaks can make a huge difference. And then finally, there will be breaks as well whenever the patient is not cooperating with the procedure. So if they're, pushing things away, trying to get out of the chair, yelling, refusing to open their mouth, turning their head away, all of those would result in the individual receiving a break to ensure safety and so that the procedure is done with their consent and increases their comfort level that it's not going to be forced on them.
Hey, Christy.
Yeah.
Do you want questions during your presentation or do you want them held to the end?
I don't have a preference. So if you would like to ask a question, you're welcome to.
Yeah. So thank you. So like from a behavior analytic viewpoint, how do we work to make sure, because I've done, steps 1 through 4. But on step 5, how do we work to make sure that that doesn't accidentally reinforce that bad behavior or the protest behavior?
So
sorry.
Yeah. So I think that when it comes to just the professional implementing these strategies, there may not be a clear differential reinforcement procedure in place. It could be, the parent contracting with the kiddo, like we'll go to the trampoline park after when you finish. And so getting through it, the reinforcement is getting to go to the trampoline park, getting to go get ice cream. And so the motivation to complete the steps could be there for that individual. So, I can take breaks, but if I want to get my ice cream, I've got to get through it eventually. So that is one way. And then if that is not, a sufficient strategy, then I think that looking towards working with a behavior analyst is going to be more in the tertiary prevention strategies. And that's where we'd want to have where we want to go to graduated exposure and really be meeting the individual where they are in terms of taking it one step at a time and reinforcing completion of each target step.
Okay, so then for me, I could talk to the professional and say, if Johnny isn't cooperating, just step back for a minute, just take a little bit, break and then come back in, maybe do something different. And then, so it's just maybe a something that I can suggest to the professional that they could do something along those lines. Okay.
Yeah. And I think for the professional that will hopefully feel like common sense, that you're not going to force a procedure, especially one that has dangerous implements.
Like the dental picks.
Yes, exactly. And I think sometimes parents, caregivers, and professionals may resort to restraint when they start seeing non-compliance with the procedure. And again, there may be a time and place for that. Like if you have to get that done right now, and that's the benefit, the benefit outweighs the risk of that restraint, then that may be what's necessary in that moment, as long as you can do it safely. But if this is, you know, a routine dental cleaning and you can come back, or you can spend a couple months working on this, and then you can come back and the individual can sit through it without needing to be held down, or, you know, had the procedures done against their consent, then that in most situations, I think is ideal, because that's going to lead to further compliance with these procedures in the future, versus if you resort to restraint or forcing the individual to go through this without their consent, you're likely going to have more problems in the future in terms of them just avoiding medical care, or needing further, more intrusive restraint and sedation in the future, because it's already been a traumatic experience for them.
Yeah, and I think it like serves two functions. One, it gives the professional permission to stop, right?
Mhm.
That they don't have to go through and force them to go through to completion.
Mhm.
And you know, it also gives the parent, you know, permission to say, it's okay, you can stop.
Mhm.
Right?
Yeah.
Because this is just a routine dental exam and we can work, and, you know, so
Mhm.
yeah. And it doesn't create an uber aversive environment for our learner or patient either. Good.
Absolutely.
Thank you.
Of course. And I think that's what's going to be important in terms of finding a medical provider who's willing to be patient. You know, and so if you're saying every 15 seconds or every 30 seconds, I need you to back off for 15 seconds, that can seem very cumbersome, but can make all the difference for that individual. And the comfort level and the, you know, how long you can work can be increased. So if you start at 15 seconds, they learn to trust that the dentist is going to stop at that 15 seconds and give them a break. Then with, you know, with more practice, you can potentially move to 20 seconds, 30 seconds, up to a minute. And so it can become less time intensive if they're willing to put in that initial effort of offering those very frequent breaks. And the last thing that I wanted to say about these prevention strategies are that, you know, these follow universal design as well. I would love it if my medical professionals did all of these things for me as well. So over the holidays, I had some pretty intensive dental work done, and I got to experience none of these in my dental experience. And I was thinking back, you know, I wish the dentist told me almost nothing about what he was doing for the, you know, 3 hours that he was working on my teeth. And I would have really appreciated if he told me what he was doing, he showing me what he was going to do. That would have been nice too. So I'm not just laying there with, you know, in pain and not sure what's happening or when it's going to be over. I wouldn't have minded if he told me I was doing a great job. I would have loved to have, you know, a movie playing or my AirPods in and listening to music. That would have certainly made it less painful. I would have liked more frequent breaks, you know, maybe every 30 minutes that I could stand up and, you know, check my phone and, you know, just take a break from having my mouth open and being in pain. And I did cooperate. But if I didn't, I would also hope that this dentist would, you know, back off and give me a break as well. And so these also don't need to be things that you only do for individuals with IDD. These would be great strategies for medical professionals to just employ in general for all of their patients. Okay. So from the article that I mentioned earlier, the Matucci and colleagues from 2023, they taught dental professionals or dental students how to implement these strategies that I just spoke about. And so they provide this really nice task analysis of what that looks like and how they were rating or scoring the dental students in implementing these procedures. So they have an initial setup, which is getting the materials ready, having potential preferred items ready, and then greeting the patient. They provided access. They were required to provide access to the reported preferred item. For most kiddos, for most individuals, I think this is going to be some kind of electronic. They were required to label the material or the instrument and explain what they were going to do with it, and then complete the described step. So that's the tell, show, do. They were required to provide praise contingent on compliance with the step. So each step, nice job, thanks, you're doing great, just letting them know they're doing well. They were required to provide breaks whenever the patient was not cooperating. So if they didn't comply with an instruction or they engaged in challenging behavior, the student needed to back off and give them 15 seconds of a break before trying again. They were required to provide frequent scheduled breaks. So there was a 15-second break between each exam step, or if the exam step lasted longer than 15 seconds, then there were 15-second breaks between steps. Or I guess between every step there was 15 seconds, but they'd get a longer break if the step was longer. And then finally, they would let the patient know that they were done with the exam and then provide some general praise. Nice job, we made it through. And that was the end. So this is what employing the professional strategies would look like during a dental session. And then finally, these procedures may not be enough for some individuals, especially for those who have already had a aversive experience at the dentist. So maybe they've already experienced restraint or sedation, or in some other way had a very aversive experience. There may be other individuals who just aren't, these procedures so far are just not enough. And so that's where ABA intervention can come into play, and where a behavior analyst may need to be involved, both because of the expertise that's required, but also because of the cost and time that would be required to implement these interventions. So a dentist or a medical professional likely wouldn't have the time and resources to implement more intensive intervention here. And so that's when we would call in a behavior analyst for support. And so what a behavior analyst is going to do, what the research supports, is all of the professional strategies that we just spoke about. And so we're telling what we're doing, showing before we do it, giving that praise, access to preferred items, those frequent scheduled breaks, and then breaks whenever the patient is not cooperating with the procedures. So all of that comes with it. But on top of that, we're adding a procedure called graduated exposure. And what that is breaking down the appointment into individual steps, small steps, and then introducing those steps systematically and gradually. So in the article that I mentioned previously, this is an example of breaking down the dental cleaning procedure into individual steps. So we start with placing the bib on the chest and hooked around the neck, putting on the mask, putting on the gloves, so just the dentist getting ready, inspecting the teeth, and so on. So really breaking it down into each step that a dentist might do during the cleaning. And for each individual, where they are in what they can tolerate is going to be different. And so you might have an individual who will happily get in the dentist chair. The dentist can get ready. They can inspect the teeth, but as soon as that toothbrush comes out, or as soon as something starts going towards their mouth, they're clamped shut. No thanks, I'm good, see you later. And so for that individual, you might start with having them open their mouth and just tolerate having their mouth open, or just like being able to poke the mirror around inside for 5 seconds. That might be where you start. For some individuals, they won't even come near the dentist chair. And so that might be step one of where you're starting, is like just seeing someone dressed up as a dentist, so they got the mask and the guard and the gown, ideally someone that they don't know or don't recognize, and having them just sit in a dentist-like chair, and then you're good to go, you're done, trial over. That might be where you start. And so with graduated exposure, you're starting, in whatever step they'll tolerate, and then gradually moving forward as they tolerate each of the steps. And what can be helpful here is making the environment that you're practicing in as similar as possible to what the dentist's office is going to be like. And so online, you can buy dental tools, $10. And they usually come with like a plastic covering on them, so they're not super dangerous to have near the kiddo's mouth or the individual's mouth, specifically when you're practicing and there may be concerns about dangerous behavior. I've had success with those zero gravity chairs and sort of replicating what a dentist chair feels like. For other individuals, we've just laid down on the floor on a mat, or like sat in a regular chair but tilted it back a little bit, so as close as possible to what a dentist office might feel like. And then having the person that is practicing the procedures or serving as the dental professional when practicing look as much like a dentist as possible. And you may start with the therapist or the behavior analyst being the one that's dressed up as the dentist, and that they're, the individual knows that it's someone that they're familiar with and that they're not in a dentist's office. But you would definitely want to test for generalization later if that was a necessary step. And so having, once you've got compliance with the full dental routine, then having someone who the individual isn't familiar with serve as the dentist through that routine, or going to the dentist's office and going through all the steps without actually having the dentist complete the procedure to make sure that the skills are strong enough before you actually go to the medical or dental appointment itself, to increase the chance of success. So, in conclusion, what I'm hoping folks today will walk away with is that behavioral strategies can be effective at increasing an individual's compliance with medical and dental procedures, reducing anxiety around those procedures, decreasing dangerous behaviors that could make the procedures more risky, or result in the dental or medical professional saying that the individual needs to be restrained, sedated, or under anesthesia to receive that procedure. And with those reductions and increased compliance, that can increase access to necessary care for individuals with intellectual and developmental disabilities, improve their health outcomes, and avoid those riskier procedures that have their own risks associated with them. And some important considerations from me: I think you can never start too early.
Start young.
Yes. So, not waiting until things are bad and you can't get the individual to go to a medical appointment, or you just kind of push through until it gets to be too much. It's a lot harder to unlearn all those aversive experiences than to just start young and start with those initial primary and even secondary strategies, so that you don't have to get to the tertiary strategies that I just talked about. I would also recommend avoiding forced participation as much as possible. So really giving those breaks for that, for those dangerous behaviors, or for an individual withdrawing their consent, so that it is a consensual participation to avoid those aversive experiences that might lead to further challenging behavior in the future. And then also a note that if those primary and secondary strategies aren't successful, that is a time where you would likely want to seek more professional intervention from a BCBA. And then a note also that these procedures may not always be 100% successful. And so there may be times where these procedures, these more intensive procedures of restraint, sedation, anesthesia may be necessary. But it's helpful to know that there are other options to consider, and that doesn't have to be the first option when an individual will not sit for a procedure, will not tolerate a procedure. Here are my references. And this is my last slide. Thank you guys so much for being here. And I think now we can open it up for comments, questions, thoughts.
Would you go back to your slide on the task analysis?
Sure. This one?
Yeah, so it's interesting. See the right-hand column?
Mhm.
I was working with a young man one time, and his the uncle of one of my service providers was a dentist.
Mhm.
And he came up like you have in here, brush bottom side with brush, right?
Mhm.
Brush surface, bottom side with brush.
Mhm.
He had a task analysis that I think it was like 27 steps long or something like that.
Uh-huh.
That got like, and he put time limits on it too. Like, it wasn't just brush the surface of the bottom side. It was like the bottom left quadrant of the mandible bone for 5 seconds or something like
Wow.
that, right?
Yeah.
And then it was really, really detailed, but I always remembered that because like when we often work to try to teach kids how to brush their teeth,
Mhm.
right? And
Yeah.
there's some that, you know, depending on where their current level of performance is,
Mhm.
there's some that this is what you need. But then
Mhm.
there's other kids that need that really more detailed type of task analysis to be able to do that.
Yeah, definitely.
And then my next sort of like observation is, we were so fortunate. We had a young man that he was pretty significantly impacted.
Mhm.
And we were just trying to get him into the dentist to put that, they paint that stuff on your teeth to prevent cavities,
Mhm.
right? Because we were still trying to work on teeth brushing with this young man.
Mhm. Mhm.
And that dentist, Christie, he let us, not only did we didn't have to buy anything, he gave us all the little picks. He gave us, you know, those little cotton things that they put in there.
Mhm.
He gave us little bulbs where we could blow air on this young man's teeth to
Nice.
pretend like he was actually in the dentist. And then once we got him doing that at home, this dentist let us come into his office and use the spare room
Mhm.
to be able to acclimate him to that room. And we were able to get this kid in there. It took a while, right? And so his parents no longer had to drive from Manhattan to Kansas City to
Mhm.
sedate him for
Mhm.
a routine dental exam,
Yeah,
right?
that's
I
huge.
mean, it's amazing. This is such an important topic for families,
Mhm.
to know that, because families are always looking for dentists that will sedate their kids.
Mhm.
But this is so important. Thank you so much for presenting this. And then the article that this comes out of,
Mhm.
did he have like any kind of outcome data? Did he like look at the percentage of kids, or was it just whether or not he was successful with the TAs?
So here, let me go to my references. This article is out of UHCL, my alma mater,
Yay.
and their focus was on training dental students and professionals. And so their data is specifically on teaching the dental students and professionals to implement these procedures. And it was also remote teaching as well,
Oh,
or
that's
remote
cool.
training. And so
All
primarily,
right, I want that reference.
well, if you email me, I'm happy to send you the article, but it's also publicly available too. And so that was their focus, but because it's such a recent article, they have a really nice lit review on the current practices, and they pulled from, you know, our evidence-based practices in order to decide what to train the dental students. And so they determined that the secondary strategies that I talked about were the most appropriate and practical interventions to teach the dental students.
So it's interesting because here at K Med Center,
Mhm.
we've, you know, we have students that rotate through our unit here,
Mhm.
and some of them are from audiology,
Mhm.
and using this same kind of strategy. They're I think their doctoral
Mhm.
project was on training incoming audiology students how to be able to use these strategies to increase compliance in kids with autism during audiology appointments.
Yeah, Yeah.
So-
These practices, they can be used for so much, any type of, task that's medical, hygiene, dental, that can be aversive, and sometimes just such simple practices can make all the difference. Or even if it gets to a behavior analyst implementing intervention, it's pretty amazing how much progress you can make in a very short period of time by slowing down and using graduated exposure, and the success that you can have when they actually do go to have the procedures done.
I like the frame of that, where it's slowing down, right? And I think part of the challenge that we face sometimes is we are such a highly mobile and fast-paced society,
Mhm.
right? That sometimes it is slowing down, right? It's like slowing down and listening to what it is that our families and our patients need
Mhm.
in order to be able to help them be successful.
Yeah.
That's a good study. We should look at that. We should do surveys. We should do a survey study on that.
And I think too, if families are trying to bring their individual to the dentist or to have a medical procedure, and that's what they're being told too, is like, well, the only option, because we can't do this with the individual without restraining, or they're refusing to do it, is sedation or anesthesia. That can feel like the only option if you don't know there are other strategies out there. And if you're going to be on an 8 to 12 month waiting list to be sedated and get your dental work, like, you could easily start working on those behavioral strategies in that time, and potentially avoid it altogether, and get them into those medical appointments faster, because they no longer need sedation to complete it.
Yeah, and especially, sorry, and then I'll quit talking so other people have a chance to ask questions. But these strategies work. I'm not just with folks with IDD, but even our neurotypical kids as well. I mean, going to the dentist office can be a scary experience. And so that show tell do sequence that you have, I mean, that is one of the things that that we talk about sometimes, our social stories. And the originator of those social stories came out and said you can't just read them a story, right? You have to have that practice piece that goes along with it. And I think any kind of medical, dental, and it goes actually beyond that. I know we're talking about medical and dental now, but any kind of non-regularly occurring event, or something that happens only once a year, right? That's a great strategy to be able to use with trying to help make it easier for our kids or people with IDD to be able to be successful, right?
Absolutely.
I think that's kind of what it's all about. But anyway, all right, I'll quit, Christy. I could pick your brain, but
Christy, I think this is a great topic. I actually did work with this on a client 4 years ago, after several years of the client being restrained at various appointments, and actually, sorry, no, it was longer than that. Time just runs together. It's been 6 years when we started it. But I think the thing that people forget, or maybe don't always realize, is by doing things like holding people down or restraining, you're teaching them that's an unsafe place. And so I went in on the psych side and did some things. And then I actually worked with a BCBA in-house. They created a desensitization program and utilized some of those tools in the house, exactly as you mentioned. And then I went with them to the appointments and not only took data on what we were seeing, but also provided guidance to the professionals across the different locations to say things like, given history, don't stand over the child. That's threatening to begin with, and you have a history of that. So I'd recommend sitting. This child can now do full-on x-rays, does not need sedated, allows us to go in. I still go to make sure we don't have any spontaneous recovery, but
Mhm.
will allow them to lean back, can do full dental cleanings, full invasive eye exams. So it's super, super cool to see,
Yeah.
because the family thought, well, we're going to have to do this. And I'm like, no, you really don't.
Yeah.
We can work as a multidisciplinary team, which is becoming more and more emphasized across the fields,
Mhm.
so that, everybody in their specialty all participates in that client's care. So we're providing this well-rounded treatment.
Yeah, absolutely. With a kiddo I worked with recently, he needed to have a blood draw. He was 8 and he hadn't had a blood draw since he was tiny, because of the resistance that the family knew he would put up, and also concerns about the COVID vaccine, and maybe 3 hours of total of practicing, and he went and got both done, and they said that he didn't even know it was real. He thought they were still practicing, because that's what we said, we were practicing when we did it, when we were not actually doing the procedure but just going through the motions, and he couldn't even tell the difference between when we were practicing and when he actually went, and that was pretty phenomenal. We were like, it's fine if he doesn't know that it actually happened. It can always just be practice. But the procedures sometimes don't have to be very intensive, and they can really be life-changing. So I feel like as much as we can get the word out, and also our medical professionals trained in implementing these secondary procedures, strategies, and trying those out right off the bat when they know they have an individual coming in with IDD or some resistance to these procedures. There are changes coming in terms of training that dental students have to receive, but not in terms of continuing education. And so hopefully we'll have our new dental professionals coming in with some exposure and training, but getting the word out to continuing education. For continuing education is still on our advocacy list.
Well, you let me know how I can pair with you on that one, because I mean, as far as coming from both angles, because
Mhm.
it's, I think again, having MDT focus, where it's like, no, multiple professionals across multiple specialties are all saying this works. We know it's effective. We have data and research to support that it's
Mhm.
effective.
Mhm.
So it's like you said, it's not just I saw it work, so I know it works, but it's like, no, we have the backing to support it. I think then yes, seeing that continuing ed for all professionals will hopefully continue to increase. That's awesome.
And it helps disseminate behavior analysis.
Yeah.
So anyway.
Well, I will check the chat one more time, Christy, if there's anyone else that has anything. And we are looking good. I want to take this time as someone who had an aversion to the dentist as a young child and still isn't the most comfortable, and had a similar experience, Christy. This was on numerous levels very educated and very just very enlightening about everything. So this is Christy's contact. This will also be sent out. This deck will be sent out along with our follow-up survey and other information. Please take that follow-up survey and suggest some more topics that you might want to see. And we will also be letting you know, if you sign up with that, we will also be letting you know about upcoming topics and our next parent cafes. So we want to thank the All In for Kansas Kids Quality Subgrant and the Kansas Children's Cabinet. And thank you all for attending today's Parent Cafe, and hope you have a great rest of your week.
All right. Thank you, Christy.
Thank you, guys.
Thanks.